What are the primary factors that influence the effectiveness of tissue fixation in histopathology, and how do different fixation methods, e.g., formalin, glyceraldehyde, affect the tissue structure and diagnostic quality? Answer: the effectiveness of tissue fixation in histopathology depends on multiple factors. Fixative choice. Common fixatives include formalin, 10% neutral buffer formalin, and glyceraldehyde. Formalin is widely used for routine histology because it preserves tissue morphology and proteins, preventing autolysis and putrefaction. Glyceraldehyde, on the other hand, is often used for electron microscopy as it preserves ultrastructure better than formalin, but is harsher on tissue, leading to potential distortion, tissue size and thickness. The fixation time required varies based on the tissue size and thickness. Larger specimens may require more time for complete fixation to ensure even penetration of the fixative. Temperature. Fixation is most effective at room temperature, but chilling the tissue can slow down the process, leading to incomplete fixation. Time of fixation. Inadequate fixation leads to poor preservation, which compromises histologic interpretation. Overfixation can also result in tissue hardening and can interfere with subsequent staining and immunohistochemistry. pH and buffer. pH affects the cross-linking process during fixation. Formalin works best at a neutral pH, and deviations can reduce the effectiveness. How does immunohistochemistry assist in the diagnosis of cancer, and what are the limitations of this technique in distinguishing between different types of malignancies? Answer: immunohistochemistry plays a critical role in cancer diagnosis by detecting specific antigens, usually proteins, in tissue sections through the use of monoclonal or polyclonal antibodies. The key aspects of IHC in cancer diagnosis include tumor identification. IHC allows for the detection of specific markers that are expressed by cancer cells, such as HER2 in breast cancer or PSA, prostate-specific antigen in prostate cancer. This helps confirm the tumor's origin, e.g., distinguishing between breast and lung cancer, differentiating between malignant and benign. IHC helps to distinguish malignant tumors from benign lesions, as malignant cells often express abnormal or overexpressed proteins that benign cells do not. Subtyping of cancer. In some cancers, IHC can provide critical information for subtyping, e.g., distinguishing between different lymphoma types or identifying the differentiation of carcinoma. However, the technique has limitations. False positive S negatives. IHC results may not always be definitive. For example, an antibody may cross-react with a protein in normal tissues, giving a false positive result. Marker limitations. Not all cancers express detectable markers, and some markers may not be specific to a single type of cancer, complicating the interpretation. Tissue availability. IHC requires well-preserved tissue, so improper fixation or poor quality tissue may compromise the results. Dr. Lewis is performing a surgery on a patient with a suspected malignant tumor. During the surgery, a rapid frozen section of the tissue is requested for intraoperative diagnosis. What are the steps involved in preparing and interpreting the frozen section, and what are the challenges associated with this technique in the context of cancer surgery? Answer: intraoperative frozen section is used to provide a rapid diagnosis during surgery, particularly to determine whether a mass is benign or malignant, or to assess surgical margins. The steps in preparing and interpreting a frozen section include tissue freezing. The tissue is quickly frozen using a cryostat machine to preserve cellular morphology and minimize degradation. Sectioning. Thin slices, usually 5 are cut from the frozen tissue using a microtome. Staining. The sections are stained, typically with hematoxylin and eosin, to allow microscopic examination of tissue structure. Interpretation. A pathologist examines the stained tissue to identify any signs of malignancy, such as abnormal cell morphology, nuclear polymorphism, or mitotic figures. Challenges. Speed versus accuracy. Rapid freezing and sectioning may cause distortion or incomplete preservation of tissue architecture, which can impact the accuracy of diagnosis. Limited material. Frozen sections may not provide enough tissue for a comprehensive diagnosis, especially in complex cases or when detailed molecular analysis is needed. What are the advantages and limitations of liquid-based cytology (LBC) compared to conventional Pap smears in cervical cancer screening, and how do they impact diagnostic accuracy? Answer: liquid-based cytology (LBC) offers several advantages over conventional Pap smears. Sample quality. LBC provides a more uniform sample preparation, which reduces the number of unsatisfactory specimens compared to conventional smears. Better cell preservation. The liquid-based method preserves cells better, making it easier to detect abnormal cells such as precancerous lesions or cancers. Additional testing. LBC allows for the additional testing of the same specimen for high-risk HPV DNA, which enhances the diagnostic sensitivity for cervical cancer. However, LBC has some limitations. Cost. The process of collecting, preparing, and testing the sample is more expensive than conventional Pap smears. Laboratory requirements. LBC requires more specialized equipment and laboratory procedures, making it less accessible in some settings. False positives negatives. While LBC is more accurate than conventional Pap smears in many cases, it is not immune to false positives or false negatives, particularly in the early stages of cervical cancer. What is Masson's trichrome stain used for in histopathology, and how does it differentiate between collagen and muscle fibers in tissue samples? Answer. Masson's trichrome stain is used to distinguish between collagen, muscle fibers, and cytoplasm in tissue sections. It is particularly useful in assessing fibrosis and tissue remodeling. The components of the Masson's trichrome stain include collagen. Collagen fibers are stained blue or green depending on the variant of the technique used. Muscle and cytoplasm. Muscle fibers are typically stained red, while cytoplasm takes on a pink color. Nuclei are stained dark blue or black. This technique is essential for identifying fibrosis in various diseases, including chronic liver disease, myocardial infarction, and certain types of cancer where collagen deposition is a critical feature of the disease process. What is fluorescence microscopy, and how does it enhance the detection of specific cellular components compared to conventional light microscopy? Answer. Fluorescence microscopy utilizes specific wavelengths of light to excite fluorescent dyes that bind to particular cellular components. The emitted light is then captured by the microscope's detector, allowing for the visualization of these components. This technique has several advantages over conventional light microscopy. Specificity. Fluorescent probes can be designed to bind to specific proteins, nucleic acids, or lipids, providing highly specific information about the location and distribution of these components. Multicolor imaging. Multiple fluorescent markers can be used simultaneously, enabling the analysis of several cellular components in a single tissue section. Sensitivity. Fluorescence microscopy is much more sensitive than conventional light microscopy, allowing for the detection of low abundance molecules. However, it has challenges. Photobleaching. Fluorescent markers can degrade with prolonged exposure to light, reducing the intensity of the signal. Overlapping emissions. Some fluorophores may emit light at similar wavelengths, which can complicate the interpretation of multicolor images. How does electron microscopy provide diagnostic information that light microscopy cannot, and what are the limitations of EM in routine pathology practice? Answer. Electron microscopy provides ultra-high resolution imaging, allowing for the visualization of structures at the nanometer scale. This is essential for studying subcellular structures such as organelles, e.g., mitochondria, endoplasmic reticulum, which cannot be seen in detail using light microscopy. High resolution. EM can detect fine cellular details including viral particles and small intracellular structures that are impossible to visualize with light microscopy. Specificity. EM can identify cellular changes associated with diseases such as the presence of amyloid deposits or the structure of viruses, making it indispensable in certain infectious diseases and rare pathologies. However, its limitations include complex preparation. Tissue preparation for EM is time-consuming and involves complex steps like dehydration, embedding in resins, and sectioning with an ultramicrotome. High cost. The equipment and operational costs are prohibitively expensive, limiting its use to specialized centers. Limited availability. Not all pathology departments have the resources for electron microscopy, making it less accessible for routine clinical diagnosis. Why is it important to use proper fixation techniques in immunohistochemistry, and how do different fixation methods, e.g., formalin, alcohol, affect antigen retrieval and antibody binding? Answer. Fixation is crucial in immunohistochemistry, as it preserves the tissue's morphology and ensures the preservation of antigens for antibody binding. Proper fixation prevents antigen degradation and cross-linking that can inhibit antibody binding. Different fixation techniques affect the tissue in the following ways. Formalin fixation. Formalin is the most commonly used fixative for HC, as it preserves antigenicity well but can cause protein cross-linking that may require antigen retrieval techniques. Alcohol-based fixatives. Alcohols such as methanol can be used for fixing tissue but may lead to the denaturation of some antigens, necessitating careful optimization of antibody binding protocols. Antigen retrieval. Some fixatives, especially formalin, may mask antigens due to protein cross-linking. Antigen retrieval methods, such as heat-induced epitope retrieval, higher or enzymatic retrieval, are used to break these cross-links and restore antibody binding. Explain the role of special stains such as PAS, GMS, and Massen's trichrome in histopathology. How do these stains help in diagnosing specific diseases? Answer. Special stains are crucial in highlighting specific tissue components that are not easily visualized with routine HE staining. For example, PAS, periodic acid SCIF. This stain highlights polysaccharides and mucus substances, making it useful for diagnosing conditions such as glycogen storage diseases and fungal infections. GMS, Grocott methenamine silver. GMS is commonly used for staining fungi, particularly in identifying fungal infections such as Aspergillus. Massen's trichrome. This stain is used to differentiate between collagen and muscle tissue, making it important in assessing fibrosis in liver, kidney, and heart diseases. These stains aid in detecting disease processes such as fibrosis, infection, and metabolic disorders, enhancing diagnostic accuracy in complex cases. Explain the advantages and disadvantages of using frozen section techniques for intraoperative diagnosis in cancer surgeries. Answer. Frozen section provides a rapid diagnosis during surgery, essential for determining whether surgical margins are clear of cancerous tissue. Advantages include speed. The procedure provides a diagnosis in minutes, helping surgeons make real-time decisions during surgery. Intraoperative guidance. It allows for immediate feedback on whether a mass is malignant or benign and helps assess the adequacy of surgical margins. However, there are significant disadvantages. Technical limitations. The freezing and sectioning process can distort tissue, potentially leading to false negative results. Limited material. The amount of tissue available for evaluation may not be sufficient for comprehensive assessment or advanced testing such as IHC. What is the primary difference between innate and adaptive immunity, and how does this distinction influence the approach to immunotherapy for a patient with chronic infections? Answer. Innate immunity is the body's first line of defense and is non-specific, responding to a broad range of pathogens through mechanisms such as phagocytosis, complement activation, and natural killer cells. It does not require prior exposure to a pathogen. In contrast, adaptive immunity is more specific and involves lymphocytes, T cells, and B cells that recognize specific antigens, leading to a more targeted immune response. It also involves the creation of memory cells, which provide long-term immunity after an initial infection or vaccination. In immunotherapy for chronic infections, understanding this distinction is critical. For patients with chronic infections, such as those with HIV or tuberculosis, therapies often focus on boosting adaptive immunity, through vaccines or monoclonal antibodies targeting specific immune checkpoints. Innate immune responses might also be targeted in some therapies, especially in immunocompromised patients who lack strong adaptive immunity. Guidelines, such as those from the CDC and WHO, emphasize the importance of considering both aspects of immunity when developing treatment plans for chronic infections. Which serologic test would be most appropriate for confirming an acute Epstein-Barr virus (EBV) infection, and how do the results guide clinical management? Answer. The heterophile antibody test monospot test is commonly used as an initial screening tool for acute Epstein-Barr virus (EBV) infection. However, EBV-specific antibody testing is more definitive. The presence of IgM antibodies against the viral capsid antigen VCA indicates recent infection, while Ig antibodies to the Epstein-Barr nuclear antigen EBMA suggest a past infection. In clinical management, acute BV infection typically presents with fever, sore throat, and swollen lymph nodes. The monospot test may give rapid results but can sometimes produce false negatives, particularly in young children or early in the infection. Thus, EBV-specific IgM and Ig tests are used to confirm the diagnosis, according to guidelines from the American Society for Microbiology. The combination of these serologic tests helps clinicians differentiate between acute and past BV infections and tailor treatment to the patient's condition. Mr. Wilson, a 40-year-old male, presents with fatigue, muscle weakness, and a butterfly-shaped rash across his cheeks. His lab results show positive anti-nuclear antibody on a test and elevated DNA antibodies. How should these findings influence his diagnosis and treatment plan? Suggests a diagnosis of systemic lupus erythematosus (SLE). ANA is a common screening test for autoimmune diseases, but a positive result alone is not specific to lupus. The presence of DNA antibodies is more specific to SLE and is considered one of the key diagnostic markers for this condition. Elevated levels of these antibodies correlate with disease activity, particularly renal involvement, and help confirm the diagnosis. In clinical management, treatment typically involves immunosuppressive drugs such as corticosteroids or antimalarials, G-hydroxychloroquine, especially if the patient shows signs of systemic involvement like lupus nephritis. ACR, American College of Rheumatology, guidelines stress the importance of monitoring antibody levels as part of managing disease activity and adjusting treatment accordingly. How does the ELISA test work in serologic diagnostics, and what are the advantages and limitations of using this test for HIV detection? Answer: the enzyme-linked immunosorbent assay ELISA is a widely used serologic test that detects specific antibodies or antigens in a patient's blood. The basic principle of ELISA involves attaching an antigen or antibody to a solid surface, adding a patient sample, and using an enzyme-linked secondary antibody to detect a reaction, usually with a color change indicating the presence of the target molecule. For HIV detection, the ELISA is used to detect HIV antibodies, usually anti-HIV1 and anti-HIV2 or P antigen. If the initial ELISA test is positive, it is typically followed by a confirmatory test, such as the Western blot or rapid HIV test. Advantages of ELISA include high sensitivity, ease of use, and the ability to process large numbers of samples. However, the test can sometimes produce false positives, especially during the early stages of infection before antibodies have developed. The CDC recommends that any initial positive HIV test result be confirmed by a second test to reduce the risk of false diagnosis. What is the clinical significance of rheumatoid factor (RF) testing in diagnosing rheumatoid arthritis (RA), and how should clinicians interpret the results? Answer: rheumatoid factor (RF) is an autoantibody that targets the Fc region of IG. It is commonly tested in patients suspected of having rheumatoid arthritis, RA, an autoimmune disease characterized by inflammation of the joints. However, RF is not specific to RA and can also be elevated in other conditions, such as infections, liver disease, or even in healthy individuals. In RA, the presence of RF, especially MRF, in conjunction with clinical symptoms like joint pain and swelling can strongly suggest the diagnosis. However, RF is not diagnostic on its own. According to the ACRULA, American College of Rheumatology European League Against Rheumatism, guidelines, RA is diagnosed based on a combination of clinical presentation, radiologic findings, and laboratory tests, including RF and CP, cyclic citrullinated peptide antibodies, which are more specific for RA. Clinicians should interpret RF levels in the context of the patient's symptoms and other tests, as a positive RF result alone does not confirm RA and can be seen in other autoimmune or infectious conditions. In the context of hypersensitivity reactions, explain the underlying mechanism of a type I immediate hypersensitivity reaction and provide an example of a clinical scenario. Answer: a type I hypersensitivity reaction, also known as an immediate hypersensitivity reaction, is mediated by Ig antibodies. Upon first exposure to an allergen, the body produces Ig antibodies that bind to mast cells and basophils. On subsequent exposure to the same allergen, the allergen cross-links the Ig on these cells, triggering the release of histamine and other inflammatory mediators. This leads to symptoms such as itching, hives, asthma, or even anaphylaxis. A common clinical example of a type I reaction is allergic rhinitis, hay fever, where exposure to pollen triggers sneezing, runny nose, and watery eyes. In severe cases, exposure to allergens such as peanuts or bee venom can lead to anaphylactic shock, which is a medical emergency requiring immediate intervention with epinephrine. The American Academy of Allergy, Asthma, and Immunology (AAI) provides guidelines on diagnosing and managing type I hypersensitivity, which often include skin prick tests and blood tests for allergen-specific Ig, followed by allergen avoidance or immunotherapy. G. Allergy shots. How does the Western blot technique differ from ELISA in the detection of HIV, and why is it considered the gold standard for confirming HIV infections? Answer: the Western blot is a more specific confirmatory test for HIV infection compared to ELISA, while ELISA detects antibodies to HIV or its components, e.g. P antigen. Western blot involves separating proteins based on their size using gel electrophoresis, transferring them to a membrane, and then probing the membrane with the patient's serum. The presence of specific HIV-related bands, such EDP and a P, confirms the diagnosis. Western blot is considered the gold standard for confirming HIV infections due to its ability to differentiate between HIV-related proteins and other proteins that may cause cross-reactivity. However, it is more time-consuming and less sensitive than ELISA. According to CDC guidelines, a positive ELISA result should always be followed by a confirmatory Western blot to rule out false positives. Mrs. Peterson, a 58-year-old woman, presents with a history of recurrent sinus infections and bronchitis. Laboratory results show low levels of IgA and IG with normal IgM levels. What is the most likely diagnosis and what immunological disorder does she have? Answer: Mrs. Peterson's lab results indicate hypogammaglobulinemia, specifically a deficiency in IgA and IgG, which are critical for mucosal immunity and protection against bacterial infections. This presentation suggests a possible diagnosis of common variable immunodeficiency (CVID), a condition characterized by low levels of multiple immunoglobulin classes, especially IgA and IgG, leading to an increased susceptibility to infections. EVID is a primary immunodeficiency disorder, and it is often diagnosed based on clinical features such as recurrent respiratory infections, along with laboratory findings of low immunoglobulin levels. American Academy of Allergy, Asthma, and Immunology (A) guidelines recommend evaluating the patient's immunoglobulin levels and assessing the frequency of infections to confirm the diagnosis. Treatment typically involves immunoglobulin replacement therapy to prevent infections. What is the role of PCR, polymerase chain reaction, in detecting pathogens in immunocompromised patients, and why is it preferred over traditional culture methods in some cases? Answer: Polymerase chain reaction (PCR) is a molecular technique used to amplify specific DNA or RNA sequences of pathogens, making it highly sensitive and specific. In immunocompromised patients, such as those undergoing chemotherapy or with HIV/AIDS, traditional culture methods may be less effective due to the low levels of pathogens present in the body, or the pathogens may be difficult to culture. PCR is preferred in these cases because it can detect even minute amounts of pathogen genetic material, providing quicker and more accurate results. It is especially useful for detecting viral infections, e.g., cytomegalovirus, Epstein-Barr virus, and fungal infections that may not be easily detected through culture. The CDC and other clinical guidelines highlight PCR's role in diagnosing infections in immunocompromised individuals, as it allows for early detection and more targeted treatment. What is the clinical significance of ANT-CP, cyclic citrullinated peptide antibodies, in the diagnosis of rheumatoid arthritis, and how does it compare to other serologic markers like RF? Answer: ANT-CP antibodies are highly specific for rheumatoid arthritis, and their presence strongly supports the diagnosis, especially in the early stages of the disease. These antibodies target citrullinated peptides, which are proteins that have undergone a post-translational modification and are present in the joints of RA patients. The presence of anti-CP antibodies in combination with clinical signs of inflammation can confirm RA even in the absence of rheumatoid factor (RF), which may be negative in some cases of early RA. ANT-CP is more specific than rheumatoid factor (RF), which can also be elevated in other conditions, such as systemic lupus erythematosus, sleep, or infections. Studies, including those referenced by the ACR, show that ANT-CP antibodies are often present before the clinical symptoms of RA appear, making them a valuable tool for early diagnosis and monitoring disease progression, and CP testing is therefore an important part of the diagnostic criteria for RA. What are the key ethical principles that a clinical laboratory professional must uphold, and how do they ensure compliance with these principles? Answer: Clinical laboratory professionals must adhere to several key ethical principles, including confidentiality, informed consent, and professional responsibility. Confidentiality: a laboratory professional is obligated to protect the privacy of patient information, ensuring that any data related to the patient's health status or laboratory tests is kept confidential. Violations of confidentiality can lead to legal repercussions under laws like HIPAA, Health Insurance Portability and Accountability Act. Informed consent: before performing any procedures, laboratory professionals must obtain consent from the patient or their representative. This ensures that patients understand the procedure, its risks, and their rights. Failure to obtain informed consent may result in ethical violations or legal action. Professional responsibility: laboratory professionals must maintain high standards of competence, integrity, and accountability. This involves following established protocols, continuing education, and reporting any discrepancies or errors in test results. These principles are supported by ethical guidelines from the American Society for Clinical Pathology (ASP), as well as federal regulations like HIPAA. Under what circumstances must a clinical laboratory professional breach confidentiality, and what protocols should be followed? Answer: Confidentiality must be maintained by laboratory professionals unless there is a legal or ethical obligation to disclose certain information. Circumstances in which confidentiality can be breached include court orders. If subpoenaed or ordered by a court, laboratory professionals must release information, though they should always ensure that the disclosure is as limited as possible to comply with the court order. Patient consent: if the patient explicitly consents to the release of their information, confidentiality can be breached. public health concerns. Under certain circumstances, such as when there is a risk of infectious disease transmission to the public, laboratories may disclose information to public health authorities. This is typically done under state or federal law. Emergencies. In urgent situations where patient confidentiality may be compromised to prevent harm. In cases of infectious disease outbreaks or bioterrorism threats, information may be shared with necessary parties, including public health organizations. In any case, laboratory professionals must follow HIPAA regulations and ensure that any disclosure is minimum necessary to comply with the legal or ethical requirement. Mr. Thomas is a laboratory manager at a hospital and is aware of a colleague who has been repeatedly mishandling laboratory samples, which could potentially lead to inaccurate test results. What should Mr. Thomas do in this situation? Answer: Mr. Thomas, as a laboratory manager, has both an ethical and professional responsibility to ensure that laboratory operations are conducted according to the highest standards. He should take the following steps. Address the issue internally. Mr. Thomas should first have a private conversation with the colleague to understand whether this behavior is intentional or due to a lack of knowledge or training. Sometimes improper sample handling can stem from insufficient training or oversight. Report the incident. If the colleague continues to mishandle samples, Mr. Thomas must report the behavior to higher management or the relevant authority within the organization, such as the quality control or compliance officer. Ensure corrective action. Mr. Thomas must ensure that the incident is documented and that any corrective action, e.g. retraining, procedural changes, is implemented to prevent recurrence. Follow the chain of command. If the colleague's behavior is a repeated or severe violation, Mr. Thomas should escalate the issue, following hospital protocols for addressing unethical conduct. How should laboratory personnel handle and dispose of bloodborne pathogens to minimize the risk of exposure and contamination in the lab? Answer: laboratory professionals must adhere to OSHA's Bloodborne Pathogens Standard 29 CFR 1910.1030 to protect themselves from exposure to bloodborne pathogens such as HIV, hepatitis B, and hepatitis C. Key guidelines include universal precautions. Treat all human blood and bodily fluids as if they are contaminated. This includes wearing personal protective equipment, PPE, such as gloves, lab coats, and face protection. Proper handling. Avoid recapping needles or handling sharp objects manually. If sharp objects must be handled, use proper sharps disposal containers. All laboratory personnel must be trained in proper handling procedures. Waste disposal. Laboratory waste that could contain bloodborne pathogens such as needles, contaminated gauze, or test tubes must be disposed of in biohazard containers that are puncture-resistant, leak-proof, and labeled as hazardous waste. Decontamination. Work surfaces and equipment should be disinfected regularly with an EPA-registered disinfectant that is effective against bloodborne pathogens. What other steps a laboratory professional should take in the event of a chemical spill in the laboratory? Answer: in the event of a chemical spill, laboratory professionals should immediately follow established emergency response procedures to ensure safety and minimize harm. The steps include: alert others. The laboratory professional should immediately notify colleagues of the spill and ensure that everyone in the vicinity is aware of the potential hazard. Evacuate and isolate. If necessary, the area should be evacuated and access to the spill zone should be restricted to trained personnel only. Personal protective equipment, PPE. The individual handling the spill should wear the appropriate PPE, such as gloves, goggles, lab coats, and respiratory protection, depending on the nature of the chemical involved. Contain the spill. The spill should be contained to prevent spreading. Absorbent materials or barriers may be used to isolate the spill. Cleanup and disposal. The laboratory professional should follow the Safety Data Sheet (SDS) for the chemical involved, which provides detailed instructions on cleanup and disposal. Spill kits should be readily available to assist in the cleanup process. Report the spill. After containing and cleaning the spill, the incident should be reported according to laboratory safety protocols, and an incident report should be completed. What is the purpose of HIPAA compliance in clinical laboratories, and how can laboratory professionals ensure adherence to HIPAA regulations? Answer: HIPAA compliance is critical to protect the privacy and security of protected health information. 5. It applies to all healthcare providers, including clinical laboratories, that handle patient information. To ensure HIPAA compliance, laboratory professionals must secure. 5. All patient information, whether in paper or electronic form, must be stored securely. Electronic systems should have password protections, encryption, and audit trails to track access to sensitive data. Limit access to 5. Access to PHI should be restricted to authorized personnel only. Employees should only have access to the information necessary to perform their duties. Training and awareness. Laboratory professionals should receive regular training on HIPAA regulations and best practices for maintaining confidentiality. This includes understanding patient rights, including the right to access and correct their health information. Handling of breaches. If the breach of confidentiality occurs, laboratory professionals must immediately report it according to institutional protocols and federal guidelines. A breach must be documented, and affected individuals must be notified within 60 days. What is the chain of command in a clinical laboratory, and why is it important to follow it? Answer: the chain of command in a clinical laboratory refers to the hierarchy of authority within the organization. It outlines the reporting relationships and establishes clear lines of responsibility for decision-making, communication, and action. The importance of following the chain of command includes clear communication. Following the chain of command ensures that important information such as safety issues, lab results, or concerns about quality control is communicated to the right individuals in the correct order. Efficient problem resolution. When problems arise, following the chain of command allows for efficient decision-making and resolution as issues are escalated through the appropriate levels of authority. Accountability. The chain of command ensures accountability by designating specific individuals responsible for making decisions or handling situations. This reduces confusion and helps maintain professional standards. Adherence to the chain of command supports ethical behavior and regulatory compliance, ensuring that laboratory operations run smoothly and effectively. What are the key responsibilities of a laboratory professional when dealing with workplace accidents, and how should they manage these situations? Answer: in the event of a workplace accident, laboratory professionals must act quickly and follow the standard operating procedures (SOPs) to ensure the safety of themselves and others. Key responsibilities include immediate response. The first step is to ensure the injured party receives immediate care, which may involve basic first aid or calling for medical assistance. Report the incident. All accidents must be reported according to the laboratory's incident reporting protocol. This helps ensure that proper follow-up and documentation occur, and that any necessary corrective actions are taken. Investigate the cause. After the immediate needs are addressed, the cause of the accident should be investigated. This may involve analyzing equipment failure, improper procedures, or safety protocol violations. Prevent future accidents. Based on the investigation, corrective measures such as retraining staff or modifying procedures should be implemented to reduce the risk of future accidents. Properly managing workplace accidents ensures a safe and compliant laboratory environment and reduces the risk of liability or legal issues. How do laboratory professionals ensure they are in compliance with safety standards regarding chemical handling and disposal? Answer: compliance with safety standards related to chemical handling and disposal is a critical responsibility for laboratory professionals. To meet these standards, they must understand chemical properties. Laboratory professionals must be familiar with the hazard classification of each chemical, including its flammability, toxicity, and reactivity. This information is typically found on the safety data sheets (SDS). Proper labeling and storage. Chemicals should be labeled with their contents, hazard warnings, and expiration dates. They must be stored according to their classification, e.g., corrosive chemicals in acid cabinets. Use appropriate PPE. Laboratory personnel must use the correct personal protective equipment, such as gloves, goggles, and respirators when handling chemicals. Disposal of chemicals. Chemicals should be disposed of according to local environmental regulations, and waste containers must be clearly labeled and sealed. Regulatory agencies such as OSHA and the EPA mandate these procedures to ensure safety and protect laboratory workers and the environment. Explain the role of emergency preparedness in a clinical laboratory, and how should laboratory professionals ensure they are prepared for unforeseen emergencies? Answer: emergency preparedness in a clinical laboratory involves planning and training to respond effectively to emergencies such as chemical spills, fires, or injuries. Laboratory professionals must ensure preparedness by emergency plans. The laboratory should have written emergency procedures for various scenarios, including fire, chemical spills, or medical emergencies. These procedures should be reviewed regularly. Training and drills. Regular emergency drills should be conducted so that laboratory personnel are familiar with the emergency protocols and can respond appropriately. Access to emergency equipment. Laboratories must have first aid kits, fire extinguishers, spill kits, and emergency eye wash stations readily available and accessible. Communication systems. Clear communication systems should be in place to alert employees to emergencies, including emergency contact numbers and alarm systems. By ensuring that all laboratory professionals are trained and equipped to handle emergencies, the laboratory creates a safer environment and minimizes the risk of injury or contamination.